Now going on to delusional disorders. Delusional disorders are stable, well-systematized, logical, non-bizarre delusions that occur in the absence of other psychiatric disorders. Since they're non-bizarre delusions, basically they're not accompanied by schizophrenic or affective or mood symptoms. So this means that the delusional disorders are a dimension independent of this schizophrenic manic continuum. So you can look at the diagram here basically below where you got S running down to M and out the side is sticking D for delusional disorders. In other words, it's orthogonal or 90 degrees to it. But there's social anxiety underlies this anxiety, paranoid, delusional continuum. And more so, it actually runs into people with paranoid delusions are actually aggressive and fighting. This seems to run opposite the flight continuum of anxiety, where you can look over to the left and you'll see the delusional and anxiety continuum making a cross with the manic and with the mood disorder and schizophrenic disorders. This is working toward this delusional spectrum, but using this coordinate system that was developed in the prior slide, I just call it the MADS cross from previous slide, using this color wheel of primary colors and the overlaps with the blends. You got the primary disorders, or primary colors, but then you got these disorders that blend into each other, and basically you can see over on the left-hand side where these disorders are arranged around in a circle of disorders, the primary disorders that are along the axis, and the blends that are in between the axes. And there's refinements or telling you what cluster A means, what cluster B and cluster C. They're personality disorders, and they're basically not as severe as the disorders that are in the middle of that circle. You start out with a spindle, you take the circle, the color circle, and basically you can match up disorders that are not along the primary axes, but they're overlaps and a combination of, you can sort of locate them like in a graph. Here's the wheel without all the colors in it. It got flipped around because it's easier to fit in with the topic. Now, down in the left-hand corner, here's a schizotypal disorder, sort of includes items that are basically included in schizoid and paranoid disorder. It's one part of the cluster A, but it could be called paranoid schizoid typical disorder. It's a combination of those. Anyway, pure delusional disorder is one of the rare disorders, but delusions are not, or a paranoid type of thinking. It's paranoia is a prototypical disorder that lends its name to many disorders in psychiatry. Paranoid delusions occur in manic depressive disorder also. So here's one of these diagrams with sets in it that basically include paranoid disorders. And as you start on the right over by pure color disorder, you see paranoid disorder. You go up in the upper intersection there and it says paranoia, and then down paranoid schizophrenia. Kreplin more or less defined these. You'll just have to read through this mainly. And of course you can see as you go from paranoid disorder to paranoia over to paranoid schizophrenia that these disorder becomes more severe. Delusional disorders have systematized delusions only. There's no predominant hallucinations, no disorganization, no negative symptoms. And here's a mnemonic down in the corner. It says regypsum, which is referential. People have ideas of reference, which so coincidental events they think will have significance and apply to them. And you can read the rest of it here. Erotic, grandiose, jealousy, persecutory, somatic, unspecified and mixed, these disorders. Usually they have delusional disorder involves these elaborated delusional systems around a central theme. If you look up in the left-hand corner, here's the delusional spectrum circle in red, and I took half of that circle to look at these delusions. The delusional disorder itself is not common, but delusions in these disorders are common. A schizotypical personality disorder has paranoid ideation, and they avoid people because of paranoid fears. So they have social anxiety, but it's over paranoid type persecution and harmful ideas that people are going to harm them or hurt them and things. Delusional mania usually has paranoia in it, also grandiosity, of course, along with the mania, and it can be confused with paranoid schizophrenia because of the irritability instead of euphoria. And paranoid manic psychosis often had mood incongruent delusions. In other words, they don't go along with the mania, they don't get grandiosity. And then borderline personality is basically one of these cluster B personality disorders. It has also basically a criteria that paranoid ideas and dissociation under distress occurs, so they can get paranoid, and it says under stress, but these people are always distressed. Schizotypical personality disorder has social anxiety based on this paranoia, but it also has a dissociative phenomena of real depersonalization and derealization. And what these are is people who feel like they're not themselves, somebody else is maybe running them and making their actions happen, and they're kind of a puppet. And derealization is where the outer situation, external situation, environment seems like it's unreal. Now these are associated with these alien and surrealistic and strange experiences. And this is associated with this first-rank symptoms that you can look back and see back in that schizophrenic history page. But they were developed originally to try to diagnose schizophrenia, but it turned out that these first-rank symptoms, they call them, occur actually more in dissociative identity disorder than schizophrenia. So those first-rank symptoms are significantly more of psychosis than they are anything. And borderline personality was split into two diagnostic categories in DSM-3, and they still overlap a lot. So, and here's some reasons why they overlap. And one of them is basically the manifestations of two different personality disorders, or a manifestation of a dimensional psychopathology. And this Spindle model is more along the lines of this dimensional psychopathology. And anyway, it says the evidence for these other three hypotheses is weak, these authors down here say. And it seems to me like I had these sets here that come from the color circle. They show you what schizoaffective disorder is like, and this borderline and schizotypical personality disorder seemed to me to be a lesser disorder that probably shows the same kind of thing, where this disorder varies and mixes together. And so basically it's mini schizoaffective disorder, I call it. Okay, now this is anxiety disorder. This is the last one. We're leaving delusional disorders now, looking at anxiety spectrum of symptoms. And this, of course, over on the left-hand side, you can see that this refers to this arousal level with panic anxiety up the top and depression down at the bottom. And then there's acute anxiety disorders kind of in the middle of that circle with panic disorder in it. And panic disorder has a lot more autonomic symptoms that people think they're having a heart attack and that they're having impending doom, that they're going to die. and things like that. And there are some physical disorders that can give the same kind of symptoms, and they'll be detailed in a later slide here. This cluster C over on the far right here, this is personality disorders that are based on anxiety and fear, and what they are is avoidant, dependent, and obsessive compulsive personality disorder. In lay literature, in a lot of articles, they're talking about this high-functioning anxiety, and this are people that are sort of fight their anxiety by being perfectionistic and hyperproductive, which actually looks a lot like people who are manic or hypomanic. And up in the right-hand corner here, it says Butcher and Carlson warn about mistaking overactivity and overarousal symptoms of anxiety for hypomania. These seem to can look a lot alike, where basically the hyperactivity is kind of a defense or a compensation for all this anxiety. I guess you could say they're working off their anxious energy in this high-functioning anxiety. And in the middle, the intersection of all of those is general anxiety and worry, where people they're worrywarts, they worry about everything. And then a little more severe on that spectrum is obsessive compulsive disorder. And these people have inappropriate, iterative, insistent ideas, images, intentions, things like that. And so their anxiety causes them a lot of distress because they're trying to resist these actions that are, a lot of them considered immoral, illegal, and very inappropriate. Things like considering killing their children, stabbing their spouse, hoping they die, things like this. Okay, this next slide is going from the spectrum of anxiety symptoms to spectrum of anxiety diagnoses. And so now looking up on the upper left-hand corner of this slide, you see panic disorder. Panic disorder causes people to actually avoid what may have caused their panic, but usually this panic disorder, it comes, quotes, out of the blue. They think it might be a dysfunction of certain nerve centers in the brain stems, and people will have a conditioning trial. Basically, whatever situation they're in, they will acquire phobia-type symptoms based on their experience. So if you're on the bus and you have a panic attack, what people will do is start avoiding buses, because that's where they had their attack, and the anxiety will attach to the bus. So, well, anyway, now the guy goes by the bus station and he has a panic attack. Well, he'll get scared of the bus station. Well, pretty soon he's at the railroad station, the same thing happens. And so a lot of these guys used to wind up having acrophobia, where they're afraid to go out, and would often become housebound. And then, of course, there's phobias where you were bit by a dog, so now you're afraid of all these dogs. It usually has a specific stimulus that sets it off, where in panic disorder, usually the panic disorder comes out of the blue, but it tends to get attached to the situation where it occurred, when this is really not causal. It's just coincidental that you've accumulated fears to this incidental situation. And then obsessive compulsive disorder, talked about that some and the rest of it. And anxious depression, you can imagine if you're anxious all the time, you're not going to be a happy person, and people do, because of the chronic anxiety and stress of that, apparently people do get depressed because of this chronic anxiousness and unhappiness, is basically what it is. Panic attacks come out of the blue, and you have to rule out hyperthyroidism, hypoglycemia, heart attack, pulmonary embolus, things like this. And you always have to rule out people taking drugs or withdrawing from drugs. People who are on sedatives can get anxiety-type symptoms of panic and things. And of course, if you take some drugs like cocaine, things like that, you could have a panic attack. It's a stimulant. FDR, Franklin D. Roosevelt, said there's nothing to fear, fear itself. And that's sort of the idea underneath panic disorders, that there is an inappropriate anxiety or panic evoked when there is actually nothing to fear but fear itself. And this underlies some of the treatment. Anxiety can cause hyperventilation syndrome, which is due to breathing out all your carbon dioxide. You get respiratory alkalosis and all the symptoms that go with that. Anxiousness can give you muscle tension and cause you to have aches and pains in your joints and your muscles. And it's like doing an isometric exercise for a prolonged time and make your muscles, joints, tendons, insertions hurt and give you fibromyalgic symptoms and like tension headaches. Got a little mnemonic here for obsessive compulsive personality disorder, that is in cluster C. It's overworked, orderly, conscientious controller, productive perfectionist, and devilishly detailed. And cluster C is basically these anxious and fearful personalities and dependent personality, obsessive compulsive personality, and avoidant personality. And then GAD, which is general anxiety disorders, pervasive, free-floating anxiety. It's not attached to any certain stimulus, but they just seem to worry about everything. They're worrywarts. Now, I'm going to talk now about catatonia, which is an interesting presentation in psychiatry. Catatonia is an interesting state, and that's where people, mainly the typical presentation is these people are statue-like, they're unresponsive to their environment, and they remain immobile. Sometimes these people can actually die because they're so immobile. They don't drink, they don't eat, they get dehydrated, they get deep venous thrombosis and pulmonary embolus, which kills them. And they can also get aspiration pneumonia. So this is a medical emergency, and these people are usually treated quite vigorously because this can be a deadly condition, just like excited catatonia and delirious mania, where basically these people in delirious mania can lead to heart failure and exhaustion because they don't drink, they don't eat, and they're hyperactive over an extended period of time. We're talking about now, if you look up at the top of this diagram on the right, these Venn diagrams again, I put flight and freeze down at the bottom, and over on the right is flight. Now these are the three famous reactions that people describe. Basically, if you're threatened, you can fight back, or you can freeze, or you can run. And Freud theorized that repression and the other defense mechanisms were an attempt at flight from anxiety. Of course, this was internal, intrapsychic, and Dollard, Miller, and Maurer translated Freud's ideas into learning theory along the lines of habit formation, this model of escape and avoidance learning. And this model is it's actually apparent in anxiety disorders, and is actually the standard model for anxiety disorders and behavior, cognitive behavior therapy and things. The two other responses of fear are known as fighting and fleeing. And you can fight out of fear, basically fighting for your life. But there's been a state induced in animals, quite a variety of animals, that is called tonic immobility. And so when these animals, they freeze is what they do. And this is thought to be a response that evolved in predator-prey relationships. Anyway, they think that this is a fear reaction, this freezing, and it's basically thought to be a catatonic-like state, and it's treatable by tranquilizers, mainly the benzodiazepines, but it has been treated by sedating antipsychotic medications. But there's some problems with the antipsychotic medications treating this. It's the last resort. They treat it with benzodiazepines, which are Valium-like drugs, and if that doesn't bring you out of this state, they'll use ECT. But the notion is that catatonia is a fear-based reaction based on the animals are basically put in a helpless state, but they still think they're having fear reaction, but they're in a helpless state, like being held down, for instance, and you can't struggle and get out of it. So you ain't going to fight it, and you can't run away, so they freeze. Recovered catatonics report severe anxiety in this state, and Moscow made a report on this, and he called it scared stiff, which is an interesting idea. Older abnormal psychology books talked about catatonia, and of course they didn't know much about the physiology of it, but they got a lot of reports from the people that were in catatonic states, and a lot of times they were actually aware of what was going on and could relate what was going on in their environment, but they had some kind of catastrophic delusions and had this impending sense of doom, which goes along with this idea of being fear-based. So medicines that work for anxiety, that's the ones they use to treat catatonic states in patients, as benzodiazepines, which is basically one of the major anti-anxiety drugs. Catatonia occurs in two states, a stupor state and excited state. And when they come out of that excited state, you have to be careful because they can become very combative and they attack people without warning and stuff. So catatonic excitement has been labeled the most dangerous psychiatric condition there is. Anyway, that's why I put this fight opposite of freeze on this arousal, psychomotor arousal level. Not all of them fight, but they come out of that excitement. They may struggle and stuff, but they can be very dangerous. So anytime people talk about catatonia in books, they warn you about the dangers of being attacked by these people. So anyway, catatonia is traditionally associated with schizophrenia, but actually is found about twice as frequently in mood disorders. And based on the hypothesis catatonia is fear-based, catatonia in mood disorders can be thought of as an overlapping appendage, as suggested by catatonia being used as a specifier in DSM-5 and as a psychotic symptom in ICD-10. And so there might be an overlapping area, just like between where schizoaffective is. It might be overlap between anxiety disorder and mood disorder, as depicted in this overlap of this manic depressive spectrum and the anxiety spectrum. And this is just a hypothesis based on this fear-based hypothesis of catatonia. And catatonia occurs in schizophrenia and has been long associated with it, but of course now it's been found that it's not the only place that catatonia occurs. It's been known for a long time that it can occur in other medical conditions. Now DSM-5 has dismissed all types of schizophrenia. They reduced them mainly to diagnostic criteria instead of types. Seems like tacitly defaulting to undifferentiated schizophrenia, perhaps. A DSM-5 list of diagnostic category, I reordered them and put them into a sequence that's much like DSM-4's diagnostic criteria of catatonia: disorganized, paranoid, undifferentiated, and residual hierarchy, because it just seems to match, and I don't think that should all be thrown away. But anyway, residual symptoms in the DSM-4 category were actually negative symptoms that remained after the acute phase of catatonia. Disorganization and paranoia and undifferentiated symptoms were resolved usually by medications or just due to the course of improving. Negative symptoms are more resistant than other symptoms of schizophrenia, so they were the ones that were residual symptoms. Going to the Venn diagram of primary colors and blends again, you can see the color wheel taken from the waste of that spindle, then modifying the color wheel as a Venn diagram, and then labeling them with my 4 basic disorders that you can see in that red kind of a triangular shape there where catatonia occurs in this color wheel, and it occurs in all these disorders actually. And so catatonia is sort of an add-on diagnosis in all these disorders. It's not recognized as a separate disorder of its own, and of course there's controversy about that. Well, this here is just a slide showing anxiety disorders opposed to delusional disorders, and that's one of the main continuums that forms an axis. And here's just more about catatonia.